Good afternoon. On the last day of the last session, I'll try and keep this lively so we can stay awake. And I'll tell you about the surgical therapy of endocarditis, review some of the history, some of the criteria for diagnosing endocarditis, look at the difference between native valve endocarditis and prosthetic valve endocarditis, identify how I think of managing, tell you a little bit about the indications, go through the surgical techniques, which are the most fun and I think you'll find the most interesting, and talk a bit about the results and focus on a couple of the specific areas of endocarditis, including fungal endocarditis and the management of patients with neurologic injury before you operate on them. Now, the history of endocarditis is quite long. We've known about endocarditis for over 300 years, and it was very intimately described by Osler back in 1985, and I'll show you his description in a second. He identified the four cardinal features: persistent bacteremia, a valvulitis, large vessel emboli, and then this immunologic vascular phenomenon. But it was many, many years until we had antibiotics before we could do anything to effectively treat these patients. From our perspective, the surgical approach to endocarditis began in 1965 when Wallace and his co-authors published in Circulation the first description of valve replacement for endocarditis. Now, here's Osler's description, and as you all know, it has not been improved upon. He had a considerable series of cases. The history is somewhat as follows. The patient has, say, aortic valve disease, so he identifies a pathology, is under treatment for failing compensation when he begins to have a slight irregular fever, an evening exacerbation of 2 or 3 degrees, some increase in cardiac pain, and a sense of restlessness and distress. Embolic phenomena may develop, a sudden pain in the region of the spleen, splenic abscess or splenic infarct, and size and enlargement of that organ. Or there is a pain in the back with bloody urine, renal infarcts, emboli, or the glomerulonephritis associated with the immunologic phenomenon. In other instances, peripheral embolization may take place with gangrene of the foot or the hand. There may be hebitude or low delirium. This is a classic picture of somebody with endocarditis. Now, many investigators have worked through criteria for diagnosing infective endocarditis, and it's been difficult. Now, the biggest advance in my mind from our perspective is echocardiographic evidence, because that really helps us look at the valve pathology, what's going on, and help us see, does this patient need intervention, or does he have an indication for intervention. The typical or major criteria as part of the Duke sort of reformulation of the basic criteria is a bacteremia or persistent bacteremia with positive blood cultures drawn at least 12 hours apart, or 3 out of 3 or 3 out of 4 blood cultures greater than 1 hour apart. With the typical strep viridans, a community-acquired Staph aureus, the somewhat atypical Haysick group of organisms, and then to really cinch it down is the echocardiographic evidence of either a vegetation, an absence, or now you have a change in your prosthesis. Now, most of the studies you see in the literature to date have focused on these criteria before we really had solid echo evidence. And now our generation is really looking at the combination of these two as we formulate approaches to managing these patients. And here's a transesophageal intraoperative echo. This was published by Joyce and Pedersen in the seminar that you see outside on the desk. But it shows a large mass here in the aorta with a fistula between the aorta and the right atrium, and color flow Doppler shows this fistula. So a lot of information is obtained by using echo. It doesn't necessarily have to be transesophageal. Briefly, we'll review the mechanism. What's the mechanism of endocarditis? Well, you need damaged endothelium. Normal endothelium is very resistant to infection. So you need a damaged endothelium. You get platelet and fibrin deposition followed by either bacterial or fungal colonization, which then promotes more platelet and fibrin, and it keeps going on and on until you have yourself a vegetation, or when the active enzymes of the organisms begin to destroy the tissue in the valve or annulus, and you have yourself an abscess. Now, what are the risk factors for endocarditis? Again, Osler described it quite well. He remarked on the great frequency with which an ulcerative changes are found in connection with sclerotic endocarditis. Whether or not in any given case endocarditis will arise depends greatly on the condition of the valve tissue. This was in 1885. So an abnormal valve predisposes to endocarditis. And for review, here are the risk factors: valve pathology, a history of prior endocarditis, and then you need some way for the microorganisms to get into the bloodstream, whether it be, as we all know, dental manipulation, some other enteric investigation, or the presence of dialysis, AV fistulas, central lines for patients on chronic chemotherapy, the immunocompromised patient, and of course the patient using intravenous drugs. So an abnormal valve and then some reason for bacteremia. Now here's a list of risk factors for infective endocarditis. And you see rheumatic heart disease led the way for many, many years, and then the presence of a bioprosthesis, either a bioprosthesis here or a mechanical prosthesis, was also a risk factor. So a foreign body in the heart, then rheumatic disease, prior endocarditis, and then the surgical lesions that you see here, VSD, aortic stenosis, mitral valve prolapse, and so on. If you look at a series of patients and compare the valve pathology depending on different eras, before 1970 it was rheumatic valve disease. And as this has declined in prevalence, it's now aortic valve pathology and mitral valve prolapse are the leading cause in multiple series for the valve pathology underlying infective endocarditis. In a series of 2,000 patients where they looked at congenital abnormalities, so this is congenital cardiac pathology, this is the incidence of endocarditis as estimated by this evaluation. An aortic stenosis lesion around 100 to 270 cases per 100,000 person years. VSD 145 and AI a significantly lower rate. And this is the reason for this is the high velocity turbulent jet that causes the damage, the fibrin deposition, and the subsequent endocarditis. So you can see the frequencies here. Now changing a little bit to prosthetic valve endocarditis and its frequency and incidence. This was worked out by Blackstone and Kirkland in the late 70s, early 80s, and they found that the incidence ranged from roughly 1.5 to 3% over the first year. And then it stabilized with a 95 to 97% freedom from prosthetic valve endocarditis at 5 years. Now, it's not a large number, but considering the number of prosthetic valves that are implanted, you can see why the incidence of prosthetic valve endocarditis is increasing. And this is the number of patients undergoing operations at the Cleveland Clinic in the article published by Bruce Lytle in 1996. And you can see a steady increase up through 92 in patients requiring intervention for prosthetic valve endocarditis. So we're seeing more and more of these patients over the past few years. Now the bacteriology varies whether it's native valve or prosthetic valve, and it varies whether it's early or late prosthetic valve. In the native valve patient, the most common organism is Strep viridans, followed by Staph aureus, and then usually a methicillin-sensitive Staph epidermidis, about 8%. Early prosthetic valve endocarditis, it's different, and the definition varies. The classical definition of early prosthetic valve was within 60 days, and it was somewhat of an arbitrary definition. This shown here is Bruce Lytle's definition, and he chose 1 year, less than 1 year within the time of valve implant as being early, because he felt that there was a change in the distribution of organisms at that time. Within 1 year, and generally in the other series that define it within 60 or 90 days, the most common organism is Staph epi. You can see the change. So Staph epi, and the vast majority of these are methicillin resistant. Staph aureus and Strep. As you go later, it starts to look more and more like native valve endocarditis, with Strep viridans becoming more common and less in the way of Staph epi. Now there's a question of whether a lot of these late still are secondary to infection at the time of the operation. But nonetheless, that's the distribution. And it's important to remember that the definition is classically 60 days. Dr. Lytle has used a year. But the importance is the change in the incidence over time. Here's the time and incidence of onset of prosthetic aortic valve endocarditis after implant. And this was published in 1984 by Eirert. And you can see with the hazard function here, it really peaks roughly at a month, month and a half, then starts to tail off, and at about 6 months or so, it's back to relatively stable risk out to here. And Bruce has cut it off here, saying anything less is early, anything beyond is later. It may be somewhat arbitrary, but the organisms that I showed you seem to change right at about this time. A couple other facts just to finish up on bacteriology. Fungal endocarditis is roughly responsible for about 5% of native and prosthetic valve endocarditis. And here's just a couple points. Bacterial resistance is increasing. We're all aware of Enterococcus that is now resistant to vancomycin. And to date, all the organisms that we have dealt with have been sensitive to some type of antibiotics. It will be interesting and frightening if in the next few years these organisms become resistant to our antibiotics. It'll change our entire, or part of our ability to treat these effectively. Well, what about antibiotic therapy? Can you cure endocarditis? In native valve endocarditis, roughly 70% of patients can be cured with antibiotics. However, 60% of these will require some late valve operation secondary to valve damage. So you can cure the majority, but they'll need to be followed because they'll end up needing some type of replacement. What about prosthetic valve endocarditis? Most patients with early, usually within the first few months, prosthetic valve endocarditis will require a reoperation. That is probably a fact. If it's late, and it's a bioprosthetic, and it's confined to the leaflets by transesophageal echo, these may be able to be cured with antibiotics, but what we find is it accelerates the degeneration of these leaflets, and they'll likely come back within a couple of years needing valve replacement for valve deterioration. Now, we looked at about 2,000 patients who, from the point of valve implant to 90 days out, who developed some sort of bacteremia, and we found 68 patients who had bacteremia at the valve implant. And after looking at them closely, roughly 20% of the patients who had a bacteremia after valve implant ended up having prosthetic valve endocarditis. If you look at the risk factors, why do you develop this bacteremia? The two most common causes was sternal wound infections and line sepsis. So you can see what we have to focus on to avoid prosthetic valve endocarditis. We have to get the lines out early, and we have to avoid sternal wound infections. Now, that may be easier said than done depending on the patients we operate on. Now, here's one approach to management. It's important that cultures are drawn before antibiotics are started so you can really target the organism appropriately. I believe nowadays you need echocardiography. It has to be serial. You can't just say the valve looks normal, we're going to let it go. If there's a mechanical prosthesis or bioprosthesis in place, there's often shielding by the valve, and you often have to use transesophageal echocardiography. EKGs need to be serial. You have to look closely for conduction abnormalities. The progression from a normal PR interval to first-degree AV block is suggestive that you have an abscess forming, so you have to look closely. And then early intervention is important. You avoid the sudden deterioration and end organ injury, which Mehmet talked about earlier, from poorly tolerated aortic insufficiency or mitral insufficiency. Now, what are the indications? If you look at the large series, 120, 150 patients for surgical intervention with endocarditis, the two most common reasons are, roughly accounting for 80%, persistent bacteremia unresponsive to antibiotics, and severe valve insufficiency, shock, or congestive heart failure. And that's the most common two causes. I bet if we had an echo in these, we would identify the patients who failed to respond to antibiotics were probably those with large abscesses or significant tissue destruction. Valve obstruction occurs, but it's relatively uncommon. Heart block is really a manifestation of ongoing tissue invasion. So that just tells you got a severe infection. Abscesses or fistulas. I think we all agree that fungal endocarditis is probably impossible to cure with pure antifungals. Staph aureus, with its array of enzymes, is probably also hard to cure. And then prosthetic valve endocarditis, as I mentioned, especially in the early phase, probably will require surgical intervention. Now, I had a third slide, which I somehow misplaced. Another indication would be recurrent emboli. The presence of a single embolic event is not necessarily an indication, but recurrent emboli is. And then finally, a questionable or controversial indication is vegetations. There's some data that suggests the presence of large, greater than a centimeter vegetation on the mitral valve is a risk factor for subsequent embolization, whereas others have not been able to confirm that. But that is something that you have to individualize and look at the patient. What are the surgical principles? Well, you stabilize if possible, but operate before shock or end organ injury, as I mentioned. Acute wide open aortic insufficiency with a diastolic pressure of 30 or 40 that's equivalent to the left ventricular end diastolic pressure is going to be poorly tolerated. So you need to consider intervening in these patients early. I think a transesophageal echo, if there's any question, or a transthoracic echo before, then we obviously use this during, and then you follow your repair afterwards. And if there's any question, you may need to get one a few weeks later if there's continued concern. But you can't assume that everything sounds good, my repair or replacement must be intact. Earlier today we talked about myocardial protection. I think most of us at the clinic use blood-based cardioplegia, antegrade and retrograde. And generally these operations take a great deal of time, especially with prosthetic valve endocarditis. We often cool the patients for those operations, and again, frequently use a large volume of cardioplegia. The cross-clamp times in some of these patients can exceed 2.5 hours. This is the most important principle. I think independent of what type of valve replacement you use, you have to debride, it has to be extensive, and you have to remove all necrotic, infected, and foreign material. And I think Bruce Lytle, what he has taught me is the following. He says you go in there, you cut it out, and then you worry about how to get it back together. But if you sit there and you say, how am I ever going to get this back together, you tend to cheat on your debridement, and then you end up with a recurrent infection. You don't close abscesses. You try and drain them into the mediastinum if at all possible. We like, obviously in the aortic position, to reconstruct with a homograft. It's malleable. It works nice. It allows you to do a lot of things. So we do that because we have access to it, but it's not necessary to fix an aortic valve. And then the question always remains, how long do you leave these patients on antibiotics? The standard is at least a solid 8 weeks. And for fungal infections, we recommend lifelong therapy. Well, what are your surgical options? In the mitral or tricuspid position, a valve repair using the standard techniques or a vegectomy is often possible. And then valve replacement, it can be mechanical, bioprosthetic, homograft, both aortic and mitral homographs have been described in both the mitral and tricuspid position. Pulmonary autografts have been successfully used, and I'll show you some photographs of that. And historically, people have described apical aortic conduits with bypass grafting, and the results of these have been quite poor. Now, patients with recurrent multiple episodes of endocarditis, usually prosthetic, who have undergone a major intervention, a couple patients have been successfully transplanted. So that's an option that one should consider if you're at the end of the surgical rope for intervening patients with endocarditis. And this is a photo from McAlpine. He was actually a thoracic surgeon out of Toledo, Ohio, and has a beautiful atlas of really, probably 1,000 photographs. I put it up here to remind us that if you're going to tackle severe endocarditis cases, prosthetic endocarditis, you have to be very familiar with cardiac anatomy. And you have to be familiar with the central fibrous body and the fibrous skeleton of the heart, and understand the intimate relationships between the left and non-coronary sinus, the mitral valve, and the tricuspid valve, because that's where all where some of the fistulas and or destruction of tissue from the annulus of the prosthesis will occur, and then the reconstruction is based on understanding these relationships. So I'd recommend, if you don't have an atlas, to obtain one and really familiarize yourself with this anatomy, because it's critical in these severe cases. And this is, again, Joyce and Pedersen's work out of Copenhagen, where they have used the pulmonary autograft to treat severe aortic root endocarditis. And here's an example. It's a little hard to display, but the head's here, the feet's here. This is the site of harvesting the autograft. This is the right ventricular outflow tract, right coronary button, left coronary button, and this is a huge abscess that went circumferentially around coronary to coronary. Mitral valves down here, and they're basically going to sew the autograft to the anterior leaflet of the mitral valve and swing it around to the ventricular septum, put a pulmonary homograft here, and you can see the stitches going in here. This is similar to what we do for homograft. This is a picture of our homograft approach. This would be in a standard homograft replacement. We, in a standard non-infected case, use 4-O-ethibond. For infected, we'll use 4-O-proline, a monofilament. We use a Teflon washer for non-infected cases. In infected cases, either a strip of autologous pericardium. If that's not available, a really nice washer is a small segment of greater saphenous vein, and you just secure it in here and tie over it as a buttress, and that works quite nicely. We use the root replacement as shown here. Here's a case of Dr. Cosgrove's where he had both an aneurysm and an infected aorta, and he formed a sort of neo-aorta using bovine pericardium to avoid leaving any foreign material in the infected mediastinal space. And this is, again, the Ross procedure, which you're all familiar with, and I just put it up here to say that I don't think anybody at the clinic has used the Ross to treat endocarditis, and I would say if you don't do 50 Rosses, that I wouldn't embark upon doing a Ross procedure in the setting of endocarditis, because it's a formidable operation, but some people have used it effectively. This is Bruce Lytle's approach to the fibrous skeleton of the heart, and what he has done, or what he recommends, is cannulating the superior vena cava quite high with the ability to transect it, allowing you to reflect it, and then connect your aortotomy incision across into your left atrium, which then exposes both the mitral and the aortic annulus. And then an extensive infection, usually when you have two mechanical or bioprostheses, you can debride the fibrous skeleton and then begin to reconstruct this either with autologous or bovine pericardium and implant valves. Now, Bruce's recommendation is to use porcine valves in this situation, because he likes the fluffy sewing ring or the bigger sewing cup and feels that it fits in these irregular areas much better. Now, with both the Carbomedics and the St. Jude, you have a bigger sewing ring you can use, and you can take your choice of what type of prosthesis you want to put in. This is from David's work. This is an error. Ignore that. But this is a patient with a root who has a abscess here, and using pericardium, the left atrial abscess is repaired. He makes a neo-aorta here, and then reimplants another valve conduit. Again, David's work. This is published for his way of managing patients with destruction of the mitral annulus, and whether that's due to numerous mitral procedures, extensive calcification, or endocarditis, he uses a strip of pericardium here to augment the fibrous skeleton, and this allows you to put in a aortic and a mitral prosthesis and going quickly through it. Here's the patch for entire reconstruction of the mitral, even when the aortic's intact, and you place your prosthesis here. The key is not to make a loose patch, because then you'll have a rocking motion of the valve, and that will tend to promote future dehiscence. Again, mitral annulus destroyed, going into the aortic annulus. And finally, a simple patch here for a posterior annulus. So here's the mitral homographs. We haven't used this for endocarditis, but some people have both in the mitral and tricuspid position. And again, if you're comfortable with mitral homographs, it's a useful tool. In all series studied, prosthetic valve endocarditis is associated with a significantly higher mortality than native valve endocarditis. This is the Mayo clinical experience covering well over 30 years, and they had the highest mortality. But I think in later series, both the native valve endocarditis mortality and the prosthetic valve is declining. This is Lytle's, I think about 146 patients with just prosthetic valve. This is David's experience with a mixture of native and prosthetic valve. And this is Larry Cohn's experience, again, with a combination. And you can see prosthetic valve endocarditis is generally found to be a risk factor for perioperative mortality when compared to native valve. What are some of the risk factors? In Lytle's work, again, prosthetic valve endocarditis only. Patients, and this is a multivariate analysis, decreased left ventricular ejection fraction pre-op, the presence of heart block, which usually reflects an invasive type of infection, coronary artery disease, and positive cultures from the aorta. Again, an active infection were risk factors. From David's experience, patients coming in shock or renal failure, again, the end organ injury, falling off the curve, liver, kidney damage, also were increased risk for perioperative mortality. From Larry Cohn's work, sepsis and prosthetic valve endocarditis relative to native valve, and again, abscess and renal failure from the Mayo Clinic series, all increased there. So you get the sense that active aggressive infections at the time of intervention increase the risk. If the patient's in severe shock and has end organ injury, you're going to see. What about long-term survival? The only factor Dr. Lytle could find was older age, and in David's experience was the functional class 4, and again, the perioperative renal failure. Now, I'll show you the results about what's the results with each of the different devices. What's the incidence of prosthetic valve endocarditis relative to replacement type? So native valve, you're doing your standard valve replacement. What's the incidence? We already know that it's a 1 to 3% from Blackstone and Kirkland's work. This shows that it appears to be increased risk with mechanical compared to biologic valves. Now, there's other studies that show it the other way, but I think the key thing that we all look at is that there's a significant or a distinct difference between allografts versus mechanical prosthesis and bioprosthesis. There's this early hazard for prosthetic valve endocarditis in mechanical or bioprosthesis that does not exist in the allograft valves, and then after a couple years they even out. So there is a finite risk with mechanical or bioprosthesis that you don't see with the allograft. What about if you have endocarditis on a prosthetic valve and you go and you replace it? What is your chance of getting recurrent endocarditis related to replacement type? And this is from Haydak's series, which was primarily or all aortic valve operations, where they used allografts, a mixture of roots and subcoronaries, versus prosthetic valves, small numbers here. But they saw the significant hazard function here for early recurrent prosthetic valve endocarditis that is absent when you use an allograft. And this has led to the sense and or recommendation that the operation or the replacement valve of choice in aortic valve endocarditis is the homograft, because it seems to be resistant to subsequent episodes of endocarditis. It's not zero, but it's lower than the mechanical or bioprosthesis. How about survival? Again, Haydak's work, again, mostly with a homograft, and this is their survival. Just note that at 5 years, it's about 64%. Now, in Lytle's hands, prosthetic valve endocarditis only, what about survival relative to prosthesis? Because you'd figure if using the homograft reduces the amount of endocarditis, then you'll probably have a survival advantage. And although his homograft numbers are relatively small, 24, he couldn't find any difference at 5 years between homografts, mechanical, and biologics. And these results are similar to David's, who has excellent results using mechanical valves in the setting of endocarditis. So I'm not sure that the use of a homograft has yet been shown to decrease or to improve long-term survival or decrease the need for reoperations. And this is the reoperation slide. This is reoperation-free. I'm sorry it's not on there, but reoperation-free survival relative to prosthesis used in prosthetic valve endocarditis, Dr. Lytle, and he couldn't find any difference between the biologic, the mechanical, and the homografts. And in fact, you could suggest that there's a hint here that maybe the homografts are requiring a little bit more reoperation. But anyway, there's no data that I'm aware of that really shows that using the homograph is going to save lives or prevent reoperations, at least to date. Some interesting data is there to suggest that, though, and this is a very recent series, 1997, from Europe, and this is the use of mainly homographs and some autographs in the setting of aortic valve endocarditis. And it's a fairly impressive freedom from recurrent endocarditis at 5 years, 96% in native and 96.5% in prosthetic. I think that's very impressive. And then the final one from this series is their survival. And at 5 years, this is some of the best survival that I've seen, 86, 87. Now, the question one has to ask, though, is this because they're using allografts and autografts, or is it because they've learned the principles taught by David and many others that you have to debride extensively, clear out the infection, and then it really doesn't matter what you put in as long as you eradicate the infection? And it's hard to tell what it is. Is it because we're doing better surgery or because we're using a biologic material? Switching gears to fungal endocarditis, the diagnosis can be difficult. The cure with antibiotics is rare in our belief, and we use a standard surgical principles. We use a homograft in this setting for the aortic valve, and then we think that you need lifelong antifungals, one of the azole agents. I throw up tricuspid valve endocarditis, just review it for the board questions. If at all possible, I'd recommend valve repair or valvectomy. You can obviously do a valve replacement. Some people have advocated valvectomy, and I'll tell you, I think the sense is that most patients with a wide open tricuspid valve don't do very well. Now, in the setting of intravenous drug use, you could argue that the return to drug abuse is going to be relatively high, and that any valve that you use, any valve replacement that you use is just going to get infected. And it may be a reasonable argument to perform a valvectomy, assuming the pulmonary pressures are relatively normal. But high pulmonary pressures in a valvectomy will be poorly tolerated. And our approach would be to try and perform some type of valve repair, even if it's not perfect. 2+ is tolerated much better than wide open tricuspid insufficiency. And here's Alan's description of some of their techniques they use for tricuspid valve. You know, the standard resection, and you could slide the posterior leaflet and bring it up in a Carpentier fashion, and anything to keep the valve intact. And here, if you can't do it, a big resection, cut out the vegetation, maybe take a trabecular muscle and make a pseudochordae, large piece of pericardium, anything, once again, to maintain some sort of valve integrity. Well, here's a young man, just to end on a case and discuss one final topic. He's in his 20s. He's obtunded. Here's his peripheral emboli. He's going into renal failure, has wide open MI. He has an infarct here, an infarct here. And postoperatively, we obtained this angiogram. He's got a mycotic aneurysm anteriorly. He had wide open aortic insufficiency. What do you do? Well, I operated out and replaced his root with a homograft. He was in renal failure. He got better. We treated him with antibiotics. We did not intervene surgically here, and he subsequently left the hospital short a few toes and fingers, but otherwise intact. And Gilinov reviewed the Hopkins experience, and I'd recommend looking at this with the management of patients with acute neurologic defects and endocarditis. Now, as Osler mentioned, it's very, very common for patients to be altered neurologically when you see them with severe endocarditis, and whether it's embolic, ischemic, hemorrhagic, just the delirium of being sick, meningitis. It's unclear at the time, but you have to have a approach or a paradigm to managing these patients. And this is one that they've recommended. It's very reasonable. Neurologic defect in active endocarditis, a CT scan, if it does not show an intracranial hemorrhage, just an embolic CVA, and the patient's hemodynamically stable, Monitor for 2 to 3 weeks, then proceed with valve surgery. If there's evidence of intracranial hemorrhage, then a cerebral angiogram. If it's an emboli without hemorrhage, so you don't see any gross hemorrhage, then you try to delay and proceed with valve surgery. If it's a ruptured myocardic aneurysm, consider neurosurgical intervention, and then you can see valve surgery. And if it's negative, you have to work up for meningitis with a lumbar puncture and treat this appropriately. I think the difficult issue is when you do have a small amount of hemorrhage, you have an altered mental status, and you have somebody that's in severe straits. How do you intervene? Should you go on bypass? And those things you have to individualize and look at the patient closely. And I'd like to leave you with that, and thank you for your time and attention.